Good afternoon, everyone. I am thrilled to discuss this topic. This topic is one of the most interesting and most controversial topics in interventional cardiology right now. So this is stratification of multivessel CAD. All right. So this is a huge topic, so I need you to bear with me, stay with me, fasten your seatbelts, and let's do this. This is just a huge topic, but this is very important for anyone who works in the cath lab, from the nurses to techs to nurse practitioners, and for all those who work before and pre and post cath lab. It is very important to know the details of this topic. So I'll be discussing appropriateness criteria, angina classification, anti-anginal medications, quickly go through non-invasive cardiac testing. I will discuss with you syntax scoring system and exclusion criteria, and go through the results of syntax and freedom trials. These two trials have changed the practice of interventional cardiology for the past few years. And to summarize and interpret of appropriateness criteria grid and the syntax scoring system. So after today, you will know if you're doing the right thing or not. So CAD, what is CAD? CAD means cath lab, right? When you hear CAD, it's coronary artery disease. So it's simply narrowing of the coronary artery. Causes could be smoking, sedentary lifestyle, hypertension, diabetes, calcification, clots, and lipids. Symptoms is if you have narrowed coronary artery, you have decreased blood flow to the heart muscles. So you have these complaints of chest pain, pressure, chest heaviness, shortness of breath, dizziness, syncope, fatigue, arm numbness, indigestion, bloating, back pain, name it. So these patients will go to their doctors. They will have this non-invasive cardiac testing. They will have this EKG test, EKG stress test, cardiac CT, MRI. And then if it's abnormal, we'll be sent to us for cardiac catheterization. So now this will lead to my topic, what if it's abnormal? What do we do? Do we treat them with medications, PCI, or CABG? Oh, I did it reverse, sorry. All right, this is a picture of a narrowed coronary artery. You see that if it's left untreated, it will be ischemic, and if it will lead to a damaged heart muscle if you just leave it alone. So this is an injured blood vessel. You see the calcification, there's a grease, the platelets are activated, and hopefully this is not inside your blood vessels right now. So take your pick. Which picture can you associate with? So this one. Where's the picture? That was me a year ago. So angina. What is angina? You always hear this, right? When you have your patients, so you work in the cath lab. Oh, I have patients with angina. What exactly is angina? Nothing. All right. It's a symptom. It's a symptom of a narrowed coronary artery. So when you hear that, it's simply chest pain, heaviness, pressure, shortness of breath. So that's angina. It's a symptom of a patient with blocked artery. So what do? We give them anti-anginals. So you will have your patient, you get your patients, you have the list of the clinicals. You'll see there are blood pressure pills. Not every heart medication is anti-anginal. Because anti-anginal, you increase blood flow to the heart muscle, it relaxes the heart. So these are the four most common, the usual that we know. It's out in the market. Beta blockers, remember your LOLs? Metoprolol, atenolol, labetalol, nebivolol. The calcium channel blockers, amlodipine, nifedipine, felodipine. But these two, they're calcium channel blockers, but they can affect the rate and rhythm of the heart. Nitrates, nitroglycerin, diisosorbides, and for the past years is Renexa. It's like a super nitrate, but it's a class of its own. So you can say that you're having maximal medical therapy if you have 2 out of 4 anti-anginals. You have optimized your medications. So because of the boom of interventional cardiology for the past couple of decades, they are under the microscope. So they said, okay, let's organize a task force to limit the abuse of opening blockages, right, left, center, back. Let's set some guidelines. Let's set strict rules to make sure that everything is done right. So different organizations from cardiology, they sat down. So this is from, so all these letters, A, B, C, D, E, F, G. So they all sat down and said, you know what? Let's set some rules. Let's set some guidelines. So what do we do now? So in 2009, I don't need you to memorize this, but just to give you a summary of what was, what guidelines was set. They said, okay, let's start with classifying the angina. class 1, 2, 3, and 4. So this is based from Canadian Cardiovascular Society. So you will hear CCS class 1, class 2. So class 1, you can do your activities. And it's like, you know what, one time I felt a little discomfort, but I can like walk 20, 30 miles, okay? Class 1. Class 2, I've been walking a couple of blocks, 5 blocks. Before, it was fine, but now it's like I've been having discomfort after a couple of blocks, so I can categorize it as class 2. Class 3, I will climb 1 flight of stairs and I'll walk a block. I get short of breath now, so that's class 3. And class 4, I can't even go to the bathroom or I can't do any activity without me getting discomfort, so that is a class 4. So you stop there, so don't aggravate yourself right now with info. And this, just to go over, so you understand the clinical that you get from the chart. So the patient will present with symptom. They will have a clinical from their general cardiologist. Was it a treadmill test? So there's a grading there, the Duke scoring system. How do they base the scoring system with the treadmill? They walk how many minutes? Is there chest pain during the test? Was there ST elevation? Was there ST depression? So there's a grading there. Stress echocardiogram. What do we see with stress echocardiogram? You see wall motion abnormality. You will see on your stress echo apical hypokinesis. Because when you stress the heart, it's either you walk on the treadmill, you do the echocardiogram, or you cannot walk on the treadmill, they give you the butamine, and then they do an echo after. You see a part of the heart that's slightly weak. It could be there's a blockage going on to that specific heart muscle. So it can also evaluate the ejection fraction. Myocardial perfusion imaging is the nuclear stress test. You will see, anterolateral wall ischemia. There's a large ischemic defect on the inferior wall. So these are the common terms that you see in the chart of the patient. And then some doctors, they just want, you know what, I don't want all this stress testing. I just want a straightforward cardiac CT. It's fine. I know an attending, she just loves ordering this. You can see the coronary calcium and just the basic anatomy of the patient. So these are just the common clinical testing done by the general cardiologist sent to our lab. So this is a very busy slide, but again, just to summarize this, the reason why I show you the slide before, there is a level of risk on the non-invasive testing. Let's just get, let's say in a nuclear test. Mild anterior defect, so it's a low-risk stress test. Let's say moderate anterior defect, so it's an intermediate risk. Large anterior defect is a high risk. So just an example, that's it. So you get your patients, the patient is prepped. Before you bring the patient to the room, as a nurse practitioner, as a technician, have the responsibility of knowing 3 variables. What's the symptom of the patient? What's the presenting symptom? Why did the patient come to the cath lab? What was the test done in the office? And what medications is this patient taking? Those 3 things you have to know. And I will tell you why it's very important. Because the last one, the coronary anatomy findings, that will be done by the fellow, by the NP in the room, and then these 4 variables will help us decide if it's appropriate to fix the blockage or not. So on your part, know the first 3. And then wait for the angiogram results, and then we decide. So here in Mount Sinai Cath Lab, everything is protocol. We are protocol driven. Everything's algorithm. Everything's guidelines. Every cath room, we have this paper. After we get these 4 variables out, we go check on the wall if opening the blockage is appropriate or not. So this is from the task force that I showed you a while ago. I is inappropriate to open the blockage. U is uncertain, but you can justify. A is appropriate. So you see the X and the Y axis. So it's either you choose one. You want to base the decision through the symptoms, or you want to base the decision via the non-invasive cardiac testing. So later we'll have an exam. It is a test. So now we've established there's a lesion. When do we do medical therapy? Patient just comes in for routine test. Patient is asymptomatic. They said, oh, there was some abnormality, questionable, indeterminate stress test. All right, some physician, they send to you, let's take some pictures. Stable CAD, very small blockage, very distal lesion, small sized vessel, blockage on the branch of the branch of the branch. I don't think we have to fix that. So another one is ischemia disappears. What does this mean? I spoke with Dr. Sharma about this, but your initial test, you have, let's say, mild ischemia, but you're not on any medication. So I will send you home on medication. Let's repeat your stress test in 3 months, ischemia disappears. It means you respond to medical therapy. So no need to do anything to you. Limited life expectancy and stage cancer within a couple of years. And basically, everybody should be on optimal medical therapy. We optimize medications, but if you're still doing poorly after the maximal medical therapy, what can we offer to you? So you have, so you improve your lifestyle and you will feel better. Then we do PCI. PCI, percutaneous coronary intervention, angioplasty, stenting, same thing. It's a non-surgical treatment to open narrow arteries to improve blood flow to the heart. 1.2 million procedures per year, 5-fold increase procedures each decade. The average length of stay is 24 hours. We've been trying to do same-day discharges for the past years. So my colleague had discussed this already. You'll be bored with this. All right, so another topic now. We go to syntax trial. So they said, okay, they established the task force. We have established that, okay, we have to screen if it's appropriate or not. Then we have to score the lesions to make sure, okay, what if there's so many blockages? This trial is a randomized control trial. You have multiple blockages. Should I send you for bypass? Should I send you for PCI? Let's check the results. How will you perform? So syntax score is purely an atomic score of the extent of CAD. CAD is a blockage 50% or more. You have a grade right away when you have a blockage 50% or more. Significant is 70%. But once we see a moderate lesion, 50%, you have a syntax score. So we accumulate all these lesions, and then we have the sum of the syntax score. Let's say you have 3 blockages. 2 plus 2 plus 2, let's say 6, so that's a syntax score. So we divided it into 3 groups. Low syntax score, less than 23, intermediate and high risk. These are the ones we're going to focus, 23 to 32, and high syntax score is more than 32. So this slide is just showing that PCI is better with low syntax score patients. And worse, when the higher the syntax score, bypass is better. So they are indirectly proportional to each other. And look at how significant the p-value is. So they just broke it down into different groups. You see the major adverse cardiac and cerebrovascular events, CABG perform better the higher the syntax score is. Diabetes. When you hear diabetes, associated with coronary artery disease. Again, after the syntax trial, these are all came together. Syntax, now the freedom trial. Freedom trial, the primary investigator is Dr. Fuster. So there are different hospitals from Europe and America, United States, 1,900 patients. Again, multivessel CAD, some with left main blockage, and then half went to bypass, half went to PCI, which performed better. 2 years and 5 years, you see that multivessel CAD, diabetic, you have to send for bypass. Everything is totally remarkable with the result with bypass patients. So for patients with diabetes and advanced CAD, CABG was superior to PCI in that it significantly reduced the rates of death and MI with a higher rate of stroke. So there's a slight increase in stroke with CABG patients. So here in our cath lab, when you read the cath report, there's a page always of the syntax score system, and there's a page of that appropriateness criteria grid. So you understand if everything's documented, even if you audit it, if we appropriately did the PCI or not. So you see the syntax score here is 37. So is it low or high? Those are not answering. I'll call you later. All right, so there's so many screened already. We screen for appropriateness. It doesn't even stop there. Now after you say, oh, it's appropriate to open the blockage, another question should be answered. Does this patient have diabetes? So there's just so many answers to it. So the rule in our cath lab, I don't know if it's across the board in different cath labs, but for us, 3-vessel CAD with syntax score more than 23, you have to send for bypass, no questions asked. Or 3-vessel CAD with diabetes, whatever the score is, they have to go for bypass. And now 2-vessel CAD involving the proximate LAD with diabetes, bypass. The Mount Sinai Heart general cardiologist, interventional cardiologist, and cardiothoracic surgeons, they have this meeting and they formulated the exclusion criteria, and they have come up with this decision that this is the criteria in making decisions for how to fix the blockage of the patient. So unless certain exclusion criteria are met, which are, if it's an acute MI, you can do, these are the list where you can just PCI the patients. Acute MI, age more than 90 years old, CVA TIA within 1 year, severe COPD, LV less than 20%, limited life expectancy, patient's firm refusal. Some patients, no matter how you say that the best option is CABG, they just don't want. You can't force them. That, like for them, just thinking of cracking the chest open, it's like, no. If you can fix, should be, and that's what they want, but you have to offer the better option. We're doing the heart-in discussion now wherein you call the cardiothoracic surgeon to discuss what will really be the best option for the patient, because sometimes they are really high-risk patients. And attending physician can be present in the lab because they know the patient well. All right, case number 1, before it starts beeping. Okay, 65-year-old presenting with mild intermittent chest discomfort during stressful situations, so class 1. Blood pressure, cholesterol, mild apical lateral ischemia, so mild, low risk, class 1. Do we have an anti-anginal on the list? Do you see any anti-anginal? No. So you have class 1, you have low risk, 2-vessel CAD, normal LV function. Oh, normal systolic. It's wrong. It's just syntax score 4. So let's go through the symptom. Class 1, right? So 2-vessel, no LAD. And then low risk, no meds. It's inappropriate to PCI. You have to send this patient home, start on medication. So what if I decide to follow the stress testing? So this is low risk, right? I find the box for the low risk. So 2-vessel, no LAD. Class 1, no medication. Even when you choose that box, it's inappropriate to do the PCI. 55-year-old male presenting with worsening dyspnea and chest pressure, walking less than 1 block for the past couple of weeks. Angina class 3, hypertension, lipids, moderate anterior ischemia. So class 3, intermediate risk. Do we have anti-anginal medication? How many? Are we maximal medical therapy? So maximal medical therapy, intermediate risk, and class 3. 2-vessel CAD, syntax 14. So let's just choose the symptom, class 3, right? So let's choose this box. 2-vessel CAD, no prox LAD, intermediate risk, maximal medical therapy. Open that lesion now. As if you set it up. All right, so let's another test. So how many vessels do we have here? So 3-vessel CAD, LAD, OM, RCA, no diabetes. So when you have 3-vessel, no diabetes, can we PCI? Yes, because the syntax score is not more than 23. So this is a PCI patient. LAD diag with just 1 vessel, CIRC, RCA. So 3-vessel CAD with diabetes. Does the syntax score matter? No. So what do we do with this patient? CABG, unless you meet the exclusion criteria. Another one, LAD, CIRC, RCA, 3-vessel, no diabetes, syntax score 28. Where do we send this patient? CABG. Very good. So in following these guidelines, Mount Sinai has performed well for the past years. There are still some occasions wherein we have done PCIs inappropriately, but the state average is 13.4, and we have ranked 3.7% only. So we've been doing well, I hope. So it's published in JAC that we have only 3.7% inappropriate rate. So I've been reviewing the charts for the past years, and all right. You can see here that even though we've set guidelines, the actual facts reveal that despite the recommendations for CABG, after heart-in discussion, 50% of the patients still elect for PCI. It is our responsibility to provide the best patient care and to provide the best patient outcomes. So, and we have set guidelines so that all of us must follow this. It is our responsibility to do the right things and only the right things to our patients. Thank you very much. Okay. All right. Okay, what are the variables to know regarding PCI appropriateness criteria? A, angina classification, maximal medical therapy. C, non-invasive risk assessment. D, coronary anatomy findings. Wow, there are 4% not listening. I'm so disappointed. Heartbroken. After discussing the benefits of CABG over PCI in certain groups, what is the most common reason why patients still choose PCI over CABG? Acute MI, CVA, previously had cath and refused CABG, age more than 90 years old. I want to know who commit the mistake. All right. Oh, come on. Good. That's correct. Thank you for your time and attention.